With the formalities in terms of introducing ourselves. My apologies.
Fine on my side.
Yes, that's
Fine
fine.
with me too.
All right, members, I can hear you. Let me then do the official introductions quickly. I'm Member Boyson, and I'm the chairperson for the Standing Committee for Health and Wellness. Can the other members please introduce themselves?
Hi there, I'm Member Leon van Wyk, member of this committee.
Morning, everyone. I'm Member Benedicta van Minnen, a member of this committee.
Good morning, Chair and everyone. I'm Member Rachel van Vogel.
Good morning, Chair and everyone. I'm Donita Stevens, and I'm a member of this committee.
Good morning, everyone. I'm Thomas Walters, a member of this committee.
Greetings to all. My name is Dwayne Jacobs. I'm a member of this committee.
Thank you. It seems to me those are all the members. Minister, my apologies once again. Over to you and your official.
Thank you, Chair and members. I'm Dr. Karim. I'm let's put my camera on. I'm the Chief of Operations for the Department of Health and Wellness. And with me, I'm just going to allow the colleagues just to introduce themselves so that our chair and members know who they are. And apologies from Minister and Dr. Kluti, of course. They're both otherwise engaged. But with me in the room, I've got, let me start with in the room with Dr. Goeieman. Ayla, you just want to say hello? I've got Dr. Goeieman, and I don't know if you're unmuting, Hillary, but I just wanted you to greet.
Good morning. Good morning, Hillary Goeieman, Director, Service Priorities Coordination. Thank you, Dr. Karim.
Thank you, Ms. Lawrence. Are you sitting there with her?
Yes, good morning. I'm Charlene Lawrence. I'm the Deputy Director for Communicable Disease Control. Thanks.
Thank you, Charlene. And then I've also got Professor Mohammed. I don't know if you can, if you're able to unmute us.
Yes, I am. Good morning, everyone. My name is Hassan Mohammed, Public Health Medicine Specialist based at Metro Health Services. Thank you.
Thank you, Hassan. Chair and members, so that's us. I'm going to share my slides, and so that we can start the presentation. And Siraj, you can just confirm that I am pulling it up. I'm just trying to open the big screen quickly.
Yes.
All good? Thank you. So let me start then. Chair and members, so you've asked for an update on the recent increase that we've had in diphtheria, particularly in the Cape Town Metro District. These are the colleagues who have prepared the slides for us. And so what I'm going to do is run through these slides and just show you, and then we can obviously be guided by yourself, Chair, in terms of answering the questions. But let's start perhaps with what is diphtheria. So I know without making it a complex explanation, it is contagious, it's potentially life-threatening, but it is a bacterial infection. And the bacterial infection causes a toxin, and that toxin is what essentially causes all the clinical symptoms, and including once it becomes systemic, gets into the bloodstream, basically, it obviously can spread to other organs, and essentially that's what it is. Symptoms usually begin 2 to 5 days, within 2 to 5 days, but there is a range after exposure of 1 to 10 days, and the symptoms generally start with a sore throat. There's loss of appetite and a mild fever, and within 2 to 3 days, you have a membrane that forms over the throat and tonsils, and that makes it difficult to swallow and to breathe. But infection can also cause lymph glands and tissues on both sides of the neck to swell, and we commonly call it a bull neck. And you'll see in the photos below what that looks like. And as I've said, it can spread via the bloodstream. Then it causes inflammation in other organs, particularly the heart and the nerves, and that can be fatal. How it's spread? It's normally spread from person to person via droplets when you cough or sneeze. And I suppose if one wants a takeaway message from all of that, I'd say that it's the way to describe it would be, and we always stress the importance of vaccination, but the way to describe it would be as a vaccine preventable disease that's caused by a toxin that's produced by a bacteria. So in short, that's what I'm describing on this slide. Immunization is obviously the mainstay of prevention, and so it is important that we focus on this slide quickly. We have, as you know, an expanded program on immunization, a schedule, and the schedule is listed there. So I'm not going to go through all of that, but essentially we vaccinate infants at 6, 10, and 14 weeks, and then we do the booster vaccinations. That's at 18 months, 6, and 12 years. And that's important, and I will come back to that a little bit later again. But what's also important is that immunity does decline following immunization. And as a result of the declining immunity, many adults can also be susceptible to diphtheria. And that's also quite important for this current outbreak that we're having. And that also means, obviously, adults working with diphtheria in high exposure risk settings, like healthcare workers, etc., they are also encouraged to receive booster doses. Both of these are all important, and you'll understand why when I come back to a description of the epidemiology of the current outbreak. Surveillance is obviously quite critical. It is a category 1 notifiable medical condition, and we have a very particular process that has to be followed when there's a clinical suspicion of a case or patient with diphtheria. I'm not going to go into all of the details, and we've tried and tested this over many years, and obviously many different types of disease outbreaks. And so the whole health department's team, workers, clinical workers, etc., as well as colleagues in the municipalities. So all our healthcare workers already understand and know what we mean when we say category 1 notifiable medical condition and what the steps are in order to notify us. That's also quite critical because it's important that we, as quickly as possible, can start our contact tracing and treat and isolate the patient, etc. Because it's obviously, because it's contagious, it's important that we really start this right from the onset. And our healthcare workers and healthcare platform knows exactly what to do. So I'm not going to go into all of these details necessarily. But in general, the public health response, so once there is a patient with a clinical suspected diphtheria, the first steps we'd obviously do is do a detailed case investigation. By that we mean look at the demographic profile of where we found the index case, look at the clinical and risk factors, obviously fill in the case investigation form. I mean, those forms are stock standard, and they essentially get collated by Ms. Lawrence in her office. Look at the line list, contact tracing, all of that. So all of that investigation is coordinated by us, by the Department of Health and Wellness. And Ms. Lawrence is our key outbreak response person there, and she does all of that and has contacts all over the province, including with the local municipalities. Then we'd want to identify close and at-risk contacts as part of that process, and there are forms to be filled in, and we follow up with all of those contacts, of course. Laboratory investigation is then the next step, and we try to isolate and culture, obviously, the bacteria. Administering chemoprophylaxis to close contacts and at-risk contacts. We then want to monitor all close and eligible at-risk contacts. So we want to keep an eye on, obviously if they from contacts might become symptomatic. And if they become symptomatic, then we'll obviously follow the normal regular procedures for somebody who we suspect has clinical diphtheria. We also want to monitor contacts in the high-risk occupations, particularly obviously health workers, vaccinate close and eligible at-risk contacts, and then make sure we just send out an alert, which goes out very quickly, usually on either on WhatsApp or emails. Ms. Lawrence's office coordinates that. There are also obviously health promotion activities and making sure we inform the communities and making sure that we inform members of the public. And then it's quite critical that we look at vaccination campaigns. And we'll come back to some of the more recent outbreaks, like at the Provincial prison, for example. But we'd want to have selective vaccination campaigns because, as I said, the immunity starts waning, and therefore adults are obviously at risk. And we'd want to improve the vaccination coverage, and particularly the children who are at 6 and 12 years of age. And I'm going to show a slide a little bit that gives members a sense of where we are currently at, and the collaboration we've had, the excellent collaboration we've had with WCED. Management of close contacts. I mean, I think those are all more or less what I've explained, and we've obviously put out some of the communication, that's examples that below in the graphic there. So how many cases have we had? And this is from January 2024 to the 3rd of February. We've so far recorded 40 positive diphtheria cases. 39 of those cases were in the Cape Town Metro, and we've had 1 case in the West Coast area. And these 40 cases include the 10 positive cases that we had. There was a cluster outbreak in one of the Cape Town Metro sub-districts in August, September of last year. There were 10 positive results from that cluster outbreak. And there were 13 cases that were linked to the remand detention facility that I've mentioned earlier. And obviously those would be adults. They were all over 20 years of age, and that would be as a result of the waning immunity. And that's why it's quite important that we focus and strengthen our vaccination campaigns. The recent outbreaks and why this, so since there's been an increase since the week 46 of last year. And there were 27 cases that were recorded from that period. So that's essentially from the week of the 11th of November to the week of the 3rd of February. So you'll see on the graph that there has been quite a significant increase in the diphtheria cases. All of those cases, as I said, are from the city of Cape Town district. Most of them were in adults. So 22 of the 27 cases were in adults. And it includes the 13 cases linked to Baltimore prison. And from the 3rd of February, there have been 8 cases reported for 2020. As at the 3rd of February, there have been 8 cases reported for 2025. So obviously, we monitor the epidemiological profile. We're monitoring this quite carefully so that we can understand whether the increase is being sustained or whether it's reducing. And we obviously put into place all our public health measures and outreach activities. And this is just a breakdown of where the cases have been in the city of Cape Town. And the majority of cases, as you can see, were reported in the southern western substructure. And obviously that includes the outbreak that we've had at Baltimore prison. This gives you just a graphical illustration of the suburbs. And as I mentioned earlier, you'll see the outbreak that we've had in Kensington. Those were the cases from Kensington, and then more recently we've also had an outbreak, 3 cases, 3 children at Chris Nissen Park, and then there were also 2 cases from Philippi and 3 cases from Strand, and that essentially makes up the majority of the confirmed cases that we've had in the Cape Metro. This is just a breakdown of the age groups, and again you'll see the majority of cases we've had are in adults. And particularly in that 30 to 34-year-old age group. And then we had 27 cases that were recorded in individuals that were over 20 years of age. And then you'll see there's obviously an increase as well in the children 5 to 9 years of age. This is just a graphical illustration and a map of where the outbreak has happened, and you can just give you a graphical sense, an illustration of where the cases are, and the reach that our teams have obviously had to respond to. In terms of our public health response, so I mean, as I said earlier, that we coordinate the outbreak response, and that's being done from the provincial office. Ms. Lawrence holds that portfolio, but there's also a team of people together with her, like Dr. Huyaman and Professor Mohammed, and there's a whole range of people in the service platform as well, who form part of that outbreak response. And as I said, it includes the local municipalities as well. So it's important to do the contact tracing and response measures, obviously, as a part of all of that team. And we issue regular circulars from time to time to alert our health workers and obviously make sure that we can have an adequate public health response. Then there's the laboratory aspect of it and the testing that has to be done. So we obviously have to liaise with our laboratory colleagues at NHLS in order to make sure that they've got the capacity to ensure that we have sufficient testing ability, and of course our clinical team then has to manage all the patients and the confirmed cases. And there's again a range of people who are involved, and particularly the infectious disease specialists who will then advise us on the management of cases and the administration of diphtheria antitoxin, which is actually the mainstay of treatment. But as I said, there's also antibiotics that are administered, and there's supportive treatment that has to be provided. So for example, if a patient can't breathe, then we have to obviously make sure that we can provide supportive care for such a patient. We have to talk about risk communication, and so there are weekly situation reports, or SITREPs if you like, that come out from the NICD, and we obviously receive it, and goes throughout the country as well. And with that, and from that reports, and with the investigations that are conducted by the team, we obviously are able then to put out messages on social media. There have been quite a lot of media inquiries as well, and we've been producing information, communication, and education materials just to help inform the general public more about diphtheria. And we obviously then look at our epidemiological response and what's required from the communities, and we can respond to the needs as well. We have intensified our surveillance and contact tracing, and obviously with the high alert that the whole province is on at the moment for diphtheria cases, this is quite an important part of our public health response. And then, as I've said, when there's a cluster outbreak, as has happened at Paulsmoor Prison or possibly in a school setting, we have to go in there immediately, and we have to obviously make sure that we can contain that outbreak as quickly as possible. And so there's a whole team of people that then jumps into action to try and contain that outbreak, because we don't want that to obviously spread much further. That's just an example of some of the IEC materials that we put out to the general public about what they need to know about diphtheria. Vaccination, as I said, is a really important part of our focus, of our public health campaign focus. And in particular, obviously, what we've now done is linking the vaccination campaign. So there's the primary series vaccination that I mentioned earlier. But in addition to that, we've also been doing catch-up campaigns. And so we have just this week started the HPV vaccination campaign, the human papillomavirus vaccination campaign. And what we've done is we have had conversations and an agreement with the colleagues from the education department. And so we are in fact doing both the diphtheria and the HPV vaccination at the same time, because it's important that we catch that group of 6 and 12-year-olds, and they obviously are mostly in schools. And so it's important that we catch that group as well. You'll see the graph illustrates how low the coverage is generally. For 23-24, you'll see that the coverage in 6-year-olds is 37%, and in 12-year-olds, it's even worse, it's 17%. So obviously, these children are at risk for getting diphtheria, but as they grow into adulthood and with the decreasing immunity to the vaccination, obviously, they're more susceptible to picking up and getting diphtheria, clinical diphtheria. And so what we've done, as I've said, we've targeted this vaccination, particularly when there are cluster outbreaks. But over and above the cluster outbreaks, there can be cluster outbreaks in those communities. I just wanted to stress that we would then also want to vaccinate everybody in and around that community. So as many people as possible within that community we'd want to reach. And so our outreach vaccination activities are geared to try and improve that low coverage, and particularly if they are unvaccinated children as well. On average, the coverage for the primary series vaccination for diphtheria is around 70–75%. So we obviously want to improve that, because if one reaches a magical sort of number of 80–85%, then there could be herd immunity. So we've been working very hard with our teams to try to improve vaccination coverage. And then, of course, the frontline staff, the healthcare workers who are exposed to diphtheria, they also should be swabbed, offered prophylaxis and vaccination. And then we work very closely with our occupational health and safety colleagues regarding exposure and increase of cases at our health facilities in the Cape Town Metro, to try and make sure that our healthcare workers are protected. And then lastly, contact tracing, screening and outreach can be resource intensive. So obviously we have to make sure that we direct our energies and our efforts to make sure that we can improve all of these aspects of the public health response, but it does require resources. For example, obviously we have to make sure we have sufficient vaccination coverage to be able to vaccinate with the HPV campaign that we're now currently doing at the moment. So we've got to make sure we place enough orders and that there's sufficient stock, of course. And I think it's important just to stress that we work with our partners. We work with the colleagues, not only just the healthcare workers, but a number of NPOs as well, who help us and just expand and improve the communication that we've got with our communities and helping us mitigate, obviously, the impact and effect that diphtheria can have. So in conclusion, Chair and members, early case detection is essential. Contact tracing is essential, and appropriate treatment, obviously, and that hopefully will minimize the spread of the infection. It's important that there be ongoing surveillance efforts and that we communicate the risk. And critical to the success of reducing the diphtheria infection is obviously vaccination, and we want to really improve the vaccination coverage. The World Health Organization has a campaign called Reach Every District. And they want to reach zero-dose children. As part of the zero-dose children strategies, they obviously want to ensure that the combination of all of these vaccination efforts can essentially improve coverage through catch-up campaigns, as well as ensuring that we improve the primary vaccination coverage as well. Chair and members, I'm going to end the presentation there. Obviously, we are available for comments and questions. I'll just put my camera off. And there we go. Thank you very much. And the team is with me, so we'll be able to answer any questions. I'm going to hand back to you. Thank you.
We appreciate the presentation, and members and the professionals, once again, my apologies for the technical delays. I'm now going to open up for questions and comments. I see the hand of Member van Minen. You may go ahead.
Thank you very much. Right, I've got a number of questions. Thank you very much for the presentation. I work in the Helderberg community, so that includes Strand, Lwandle and Chris Nissen Park. And I have been very concerned with the last couple of weeks with the diphtheria cluster outbreaks that we've seen here. The ward councillor tells me that the department has really been making a big effort to get into those communities to ensure there's vaccinations. There are just a couple of issues I want to check on. One, in terms, particularly with adults, is there a link to TB in as much as does TB weaken the immune system so that something like diphtheria would have more opportunity? That's one thing I want to ask. And then in terms of the vaccinations, if they're only sitting at 37% of children at age 6, when is this vaccination supposed to be administered in relation to the other vaccinations that are administered at clinics? And is this low vaccination rate mirrored with other vaccinations that children receive, or is diphtheria something that is an outlier in terms of having such a low vaccination rate? Because that really is a concern in poorer communities where one potentially has children with slightly compromised immunity systems for various reasons. And what can we do to ensure that that vaccination rate is improved, and how can we ensure that children get their proper vaccinations when they should be getting them? Because this is a disease that does not need to be out there, does not need to spread through the community. So we really do need to get a handle on it. Thank you.
Thank you, Member van Menen. Are there any other hands? In the absence of that, the department may respond. Thank you.
Thank you, Chair and members, and I'll also ask the colleagues to jump in as well. But anything that weakens the immune system will obviously predispose people to increasing infections. We were, as part of our presentation to Treasury, as we've been going through our requests for funding, through the MTech processes, we presented our immunization coverage, general immunization coverage. So remember, you're absolutely right. The immunization coverage has been going down, and that obviously places people more at risk. Now, following the COVID campaign and COVID vaccination, obviously, members can understand how important it is to ensure that we continue the vaccination programs, but the vaccination coverage has generally been, in fact, going down. And obviously, and this has been part of our presentation to Treasury, because that will require resources, it will require funding, and will require us to redirect funding to make sure that we can sustain the vaccination program. But I'd like let me start on Ms. Lawrence, and if she wants to comment on any of that as well. And I don't know, Professor Mohammed, if you want to comment on the issue of TB and any other immunocompromised clinical conditions as well. Ms. Lawrence?
Thank you, Dr. Karim. So I just wanted to add, in terms of these ongoing strategies, where we would want to improve our 6 and our 12-year vaccination. And as part of the Reach Every District strategy, it includes things like having that service level agreement to strengthen the public-private partnership in provision of immunization services throughout the province. It's also for us to ensure that we do the catch-up services at all our health facilities, and that we reached all those children that missed vaccination, their doses at 6 and 12 years of age. And this means that even at our health facilities, in curative services, that we also, including children that are hospitalized, that we check if those children are up to date with their vaccinations. In our early childhood development centers, we also need to reach out to them and ensure that our primary level vaccinations are done. And of course, our school health program and our catch-up activities in our schools needs to be really put into place as well. So that's just some of the strategies that I'm alluding to. And also in our ward-based outreach teams, that they actually also check the road to health cards of all children and when they visit households, etc. Thank you.
Thank you. Professor Mohammed, do you want to comment on the issue of TB?
Yeah, thanks, Sadiq. So, yeah, I mean, I'm not aware of specific data around the relationship between TB and diphtheria, but I think as a general principle, you know, where someone is immune compromised, they're more at risk of developing infectious diseases. Specifically, you know, what there is a lot more evidence for is with HIV, and certainly with a number of the cases who've developed severe diphtheria, they've been HIV positive as well, and particularly those that are not, you know, well controlled on the medication. So, you know, there is a concern. I think you're right to say that if there's any immunocompromise present or depressed immunity, then one would need to be concerned about developing diphtheria. and also developing severe complications of diphtheria. I think important to mention is that there's a range of presentations with respect to diphtheria. Some people are quite severely affected, others have a milder form of infection, and then there are others who don't have any symptoms, but they would still be infected. So this is one of our challenges, and this is where contact tracing is very important. So we screen all those who are contacts of a case just to check if any of them have diphtheria, and if we do find them, then they are treated. For example, in the outbreak at Paulsmoor, we had one case presenting. We screened roughly about 50 people, and we found an additional 12 people who had diphtheria, most of whom did not have symptoms of diphtheria, but we could treat them, and by treating them, we then prevent, the further spread. But one of the things keeping this outbreak going is that there are people walking around not aware of the fact that they, possibly might be colonized with diphtheria, and because they don't have severe symptoms, they're not necessarily seeking healthcare. So again, comes back to what you, Sadiq, and what Charlene said, is important to have good levels of immunization or vaccination coverage, and that's certainly one of the key strategies that we are using. Thanks.
Thanks, Hassan.
Member Windvogel, you had your hand up. I see you dropped it again.
Thank you, Chairperson. Let me also welcome the presentation. I'm actually partly covered by the professor. That's why I lower my hand, Chair. But I also want to understand, given the seriousness of this illness, I think Dr. Karim mentioned about the awareness program, but can they please be specific when it comes to the awareness campaign? Because I visited Swellendam and also Worcester Clinic since last week, and standing there for nearly 2 hours, there was nothing of such awareness campaign. So I just want to understand or want to know what type of campaigns, or are you just distributing pamphlets or just putting the pamphlets there at the clinic and people must take it on their own? I really want to understand the type of campaign that you are running. Thank you, Chair.
Thank you, Member. Dr. Karim, over to you.
Yes, thank you, Member Windvogel. No, obviously there's quite a range of campaigns, and I'm going to ask Ms. Lawrence to come in as well. So it's not just a matter, obviously, of producing the pamphlets and leaving it there. It's also out on the general public media and social media, on the radios, trying to get the message across to the communities around the importance of vaccination and the importance of looking out for symptoms of diphtheria, as we do regularly when we have measles campaigns, etc. So, I mean, they are quite focused campaigns. And then, as Professor Mohammed mentioned, we know when there's a cluster outbreak as well, it's quite important that we go into that community with our healthcare workers, and that we obviously inform the community about diphtheria and about the risks and how to prevent it, etc. But Charlie, do you want to add to that?
Yes, thanks, Sadiq. So yes, we've prepared all these pamphlets, which has been there for a couple of years already, but we also used our communication unit to spread the word further through alerts and responses to media inquiries. There was also a national alert that was sent out from the NICD as well. And we also highlight this with all our stakeholders. We specifically also mentioned it during our engagement with the Western Cape Education Department, where we will try and work more closely with them in getting out the information about the importance of vaccination. But certainly we can improve on our communication strategies as well. Thank you.
Yeah, thanks, Charlene. Thanks, Chair. So if you remember, we've, for example, working with our education colleagues as the HPV campaign rolls out, and so they've got a whole lot of materials that we're going to through the WCED, would obviously ask that the children give to their parents, and so that the parents can also be better informed. So it is a combination of a range of strategies. And of course, members like yourselves who are in the communities out there, you will help us get the word out.
Members, any more questions or comments? I don't see any other hands. It's going once, twice. Dr. Karim, it seems to me that we've exhausted our inputs from our side. And I would like to say to you and your team, thank you very much for making the time to come and brief us as a committee. You are more than welcome to exit the meeting. We will then now deal with committee stuff. Thank you very much.
Thank you, Chair and members. Have a good day. Thank you.
Thank you.
Bye now.
Thank you.
Thank you.
Okay,
Bye-bye.
bye-bye.
Members, it's now back to us. Any recommendations or resolutions regarding the briefing and presentation we just had?
Nothing from my side, Chair. It's a new thing for me. So, yeah, it's an ongoing learning process.
Thank you. Thank you, Member Van Vollen. Member Waters.
Chair, there was something that Member Windvogel raised that interested me. The communication and the awareness campaigns around outbreaks like this. Now, it's one thing to have it on social media. Look, I'm not saying that but to communicate this was bad, but I think you can always improve. And I was wondering whether we cannot have in the future a report on how outbreaks like this is communicated, so that we I think we need to have comfort that this is done effectively and according to best practice and appropriate to the problem. I would suggest that as a recommendation, that we assess communication campaigns around serious outbreaks like this. Thanks.
Thank you, Member Walters. That's noted. Member Van Minen.
Thank you. Look, the issue of vaccinations is something that I think, maybe being a child of the 1970s, is really close to my heart. These illnesses are preventable if people are vaccinated. Now, with babies, they tend to be vaccinated at baby clinics. However, when kids are 6 and 12, it's either at the school or it's dependent on the parents to ensure that those vaccinations are kept up to date. And I really think that we need to support the department in their efforts to extend vaccinations and to ensure vaccination coverage. But I also think we need to bring some kind of resolution to the fore, which, sorry, I'm sort of speaking as I'm thinking, which supports and encourages cooperation between health and education to ensure that those vaccinations happen. I know the department doesn't like children being kept out of school, but quite frankly, if the health department turns up to school to do vaccinations, I think that should be very much encouraged. I also think that we should be encouraging efforts within the communities with NGOs to ensure that vaccinations happen. I am concerned about vaccination rates in general, and particularly what was said about funding. I think we need to investigate what the issues are there with funding. I do not know if there is any link to American aid money and that, but that'd be something else that'd be interesting to explore. Because quite frankly, every kid that gets ill with a preventable, vaccinationable disease is an extra drain on the system, just financially. And that's not even taking into account the issues of sick children in the community. So I think this is something we should take very seriously. It's not just a tick box exercise we should check 4 times a year, but really, I would propose making it one of the real goals of this standing committee in the next financial year to ensure that we really monitor and oversight what is happening with vaccinations, because it is the absolute guiding light when it comes to prevention, particularly with children who are immunosuppressed with TB, with HIV, and I think it's something we cannot overemphasize. Thank you.
Thank you, Member Van Minen. Member Walters, follow up.
Chair, listening to Member van Minnen, I would like to make an addition. It's not a, it's, I think a proposal is a standalone proposal that I support, but it did lead me to thinking that there's an amendment maybe required to my own proposal. And that is, I think we should look at what is the ongoing awareness programs and educational programs as well. So my recommendation was really looking at the reactive efforts when there's an outbreak, but what are the proactive communication? What is the involvement of NGOs, churches, community-based organizations on an ongoing basis, schools on an ongoing basis to make people aware, parents aware, children aware of you know, what you can do to prevent problems like this. And I also would also like to suggest, from a cost point of view, prevention is always better than the cure, both from a state fiscal point of view as well as a personal fiscal point of view. The cost of diseases, the impact on families, the impact on the prospects of the rest of the family, all of that, I think, is part of the package of why prevention is better than the cure. And so I would like to add that to my proposal. What are the preventative communication? How is the community involved? How do we empower people with knowledge? How is their ongoing relationship between health services and the broader community? And let's explore that. Let's see whether there's something where we can add value. Thanks.
Thank you, Member Walters. Member van Wyk, what is your take in collaborating with the Department of Education?
Yes, I think, you know, I'm in support of what both Member Walters and Member van Minnen said. So I think that is, you know, it's important that we do, you know, emphasize the points that they've made. You know, I don't want to go through a repetition of that. Obviously, what we just need to try and do is to succinctly then just put, you know, get that wording together on the type of work that we should be encouraging the department to do, and then, you know, for us as a committee to keep monitoring and have oversight over that. Thanks.
Thank you, Member van Wyk. No wonder it has been a mouthful. Did you get the gist of it? I know we will always bring out the draft and then we'll panel beat, you know, like if there's anything that needs to be added. But did you get the gist, no wonder?
Morning, members. Morning, Chair. Yes, Chair.
All right, all right.
Yes.
Thank you. Thank you, and sorry for stressing you out this morning, no wonder. Technology and AI is something else, but at least we're back on track. Members, then we're going to continue. We will draft the recommendations and disseminate, and then we will panel beat it after we've received it from Nomonde. Can we then now go to the next item, which is observations and adoptions? And I think the first on the list is the minutes of the 29th of November, 2024. I take it that we've had an opportunity to go through it. Any matters arising from the minutes, or do we agree with the minutes? And if so, can I have a proposer and a seconder, please?
Yeah, I propose.
Member Walters proposed the minutes. Any seconder? Seconded by Member Stevens.
I will second, yeah.
Thank you. Monday, can we go to the draft committee program? I think the same is applicable here, members. It's a matter of do we adopt? There's the draft program, members, and I think we've already had our first kickstart for the year, and that is the remaining program. Happy with the program, and if we are, Member Van Wyk.
Thanks, Jay. The one question that just puzzles me is at what stage do we get an update of the financial and the budget position within the department? Because we are now, by my calculation, we are now into the last quarter. And getting into the beginning of February, presumably there should be financials now for the first 9 months of this financial year. Now, how, and it's a question I sort of ask on how do we as standing committees get briefed on the quarterly results of the departments? I don't know if I've missed something somewhere along the line, but it is something that just puzzles me. As a standing committee, I would have thought that we should be getting that type of information.
Okay, we'll keep that in the back of our minds. Let me give over to Member Van Vogel quickly. Member Van Vogel. Member Van Vogel, I see your hand is up.
Yes, Chair. I'm just wondering if you look at the program, the visit to the EMS. I'm not sure if I'm at the right page. Are we dealing with the program? What do you call it for the come again?
Program.
Yes,
no, you're right. It's the committee program. Yes, you're right.
Yeah. So I'm just wondering, can't we then include, because EMS is the road to EMS is the same road we are passing in Paarl Hospital. Can't we add for their day? At least we are doing 2 visits to Paarl Hospital and to the EMS section or headquarters. Can't we just add that also into that specific day? That's just a proposal from my side. Thank you.
Remember that makes sense. You guys who know the metro. To me as a farm boy, it makes sense. What is the sense of the other members? If it's on the same route, then it makes sense.
Namonda can tell us also if I'm correct. I'm not sure, but that's my understanding.
There's somebody? All right, I see a thumbs up. I see a thumbs up from Member Stevens. She's also on that route. So I think we will adjust it accordingly, and I see Namonde has slotted that in. So with that amendment, Member Van Vogel, yeah.
Sorry, interrupting you, Chairperson. My apologies. I'm just wondering, on the metro one, because I saw something about metro. Do we have a specific, because I don't see, I'm not sure if it's you mentioned Carl Bremer, or who was the other one, or one of the members when we were visiting Kailicha mentioned Carl Bremer, and then I think Member Donna, she mentioned something about Kraaifontein. Now I'm not sure if you when we refer in this program to metro, which have you decided which one?
Can I just raise my opinion, because I have picked up something, in the corridors. I think when we discuss where we want to go to, like Carl Bremer, Paarl, etc., let's make mental notes of that. I don't want that to appear on the program itself, because it leaks and we get red carpet treatment. So I think amongst ourselves, we can have that communication. but then we should not give them lead time, by disclosing on our unannounced visit, and put it in black and white so then everybody knows, and we will get there and we will get red carpet treatment. So but we take that in mind. Let me say we will visit those institutions. It's just a matter of how we're going to address it amongst ourselves. Member van Menen?
Thank you, Chair. I think that's a very important point you make. I don't really see the point of oversight if everyone has weeks to prepare. If one wants to do proper oversight, one needs to go to a facility and actually do oversight properly. There's a difference between oversight and stopping health professionals doing their jobs and interfering with their jobs. We understand that. But to have to go and announce what we're going to do weeks in advance, quite frankly, negates the point of doing it altogether. And I must be honest, I don't see the value in oversight visits if one is going to announce that you're going, because all you're going to get is a curated visit. And that's not to criticize any government organizational structure, it's just human nature. And I think it is very important that people understand that the committee is going to take their job seriously and they're going to do oversight properly. Thank you.
Thank you, Member van Menen. Member Van Vogel, follow-up.
It's a legacy, and I agree with you.
Oh, all right. Okay, we then in agreement that we will communicate amongst ourselves on the 11th hour. But these mentioned institutions, we will definitely go and pay them these unannounced visits. And any proposal for the amended program?
So I propose for
proposed by Member Van Vogel. Any seconder?
I'll second that, Chair.
Seconded by Member Stevens. Thank you very much. Our next point is the tracking document, Nomonde. Right, colleagues, there we have it.
Hi, Chair, and the
Yes,
members.
Nomonde.
The tracking document consists of all the resolutions, committee decisions. So you can see here, maybe I must just try to minimize here. Okay, we started our meeting last year on the 4th of July. So you are going to see the committee decision that was taken. It was the election of the chairperson, and you were elected chair in that particular meeting. And it will show you here that the file is complete, which is for that particular meeting. So members can just peruse and see where we are. From July last year, it's going to end on the 31st of March this year.
Thank you, Nomonde. So, colleagues, there is a legacy document, and we will have our add-ons as we go along with our daily activities. I think that is pretty straightforward, and it's a living document. So, members, can we take note of it? Let's have a glance over it, and it's a true reflection. Members, can we take note of it?
We take that.
Thank you, Member Van Wyk. And Nomonde, the last one is the quarterly reports.
What is going on?
We understand the cloud issues. Just waiting for the display.
Please give me time, Chair. I'm still trying to close some of the stuff here.
I know the members have been very patient with me this morning, so patience is our virtue for the day. I owe every one of you a Coke in our next face-to-face. All right, there we go.
Chair.
All right, members, there we go. It's been displayed, the quarterly report for July to September and then October to December. And we did peruse it. And just then adopt it, give our comments and whatever matter might be and your issue. Member van Wyk?
Yeah, what I mentioned earlier, this whole question of getting quarterly financial reports. Now, I don't know if Nomonde can help us on that. When do we as standing committees get access to those financial reports so that we can have oversight over what has taken place? As I recall, probably around about August last year, we received, when we had the introduction to that introductory session that we had for health and wellness, they then provided us with a year-to-date set of financials, which was round about to, I think, covered up to June or possibly up to July. We then came to the period on in late November, early December, when we were dealing with the adjustments, appropriation matters, that we then received an update on the financials at that point. And so now December and January has passed us again. And, at what stage do we get a better picture of where the department's finances and their budget stands in terms of the year to date, and we are now into the last quarter of the financial year. And that's just a question that I'm asking out of a matter of ignorance. Certainly knowing from the municipal, from the local government environment, those quarterly reports religiously come to the council every quarter. And, I'd just like to understand how that works at provincial government level.
Thank you, Member van Wyk. Member van Wyk, I would, from where I'm sitting, I do believe there's no harm. The more we know as members of this committee, the better the relationships as well. So I think we should take that as part of our recommendations, like going forward. Like we would like to see the quarterly year-to-date finances and patterns as well, so that we can be on the same page with the professionals. So I really don't think that would be an overstretch. The more we know, the better for everyone. So I'll take that. Can I take that, members, as a recommendation?
Yes, I think we should. Hopefully one of the colleagues will agree with me.
Yeah, I see some thumbs up from Member Stevens and them. All right, we'll make that as a resolution on Monday. And we also adopt the quarterly report as it is in front of us. And just going forward, we'll then add the recommendation of Member van Wyk. Colleagues, is there any other thing that I might have missed out on? If not, If not, I would really want to say, colleagues, once again, thank you for your patience with my technical issues this morning. And the meeting is adjourned until the next date of the next meeting. Thank you, colleagues.
Thank you very much.
Thank you, guys. Thanks,
Thank you,
Nomeza. Cheers.
Thank you.
Chaisa.
Thanks very much. Cheers.
Ciao.